Masquerade of Malignancy, Intra-Abdominal Splenosis uncovered during septic evaluation. Introduction. Splenosis is an uncommon but clinically significant sequela of traumatic splenic rupture or splenectomy, characterized by autotransplantation of splenic tissue throughout the body. These ectopic implants most commonly localize to the peritoneal cavity but may disseminate widely, often remaining asymptomatic for decades. On cross-sectional imaging, splenosis can closely mimic metastatic disease, lymphoproliferative disorders, or peritoneal carcinomatosis, creating substantial diagnostic uncertainty. Recognition of this entity is particularly important in acutely ill patients, where incidental findings may prompt invasive evaluation or oncologic workup. We report a case of intra-abdominal splenosis incidentally identified during the evaluation of sepsis, highlighting the importance of clinical context and prior surgical history in avoiding misdiagnosis. Splenosis confirmed with scintigraphy. Figure 1. Heterotopic splenic tissue on cross-sectional imaging and scintigraphy. Case presentation. A 60-year-old man with a history of childhood splenectomy following traumatic rupture presented with acute fever, malaise, severe headache, abdominal pain, nausea, non-bloody, non-villous emesis. He was febrile and tachycardic, meeting systemic inflammatory response syndrome criteria. Laboratory evaluation revealed leukocytosis with neutrophilic predominance, left shift in relative lymphopenia. Computed tomography of the abdomen and pelvis demonstrated multiple soft tissue nodular lesions scattered throughout the pelvis and peritoneum, raising concern for metastatic disease. Empiric intravenous ceftriaxone was initiated. Antimicrobial therapy was brought into piperacillin tazobactam with tobramycin due to persistent sepsis. Blood and urine culture subsequently grew Klebsiella aerogenes, prompting antibiotic de-escalation to cefepime. Given the patient's known history of traumatic splenectomy and prior counseling regarding residual splenic implants, intra-abdominal splenosis was favored over malignancy. Tumor markers were mildly elevated. Carcinoembryonic antigen 4.5 nanograms per milliliter, PSA 4.17 nanograms per milliliter, felt to be reactive in the setting of acute infection. Nuclear medicine imaging with technetium-99m label heat-damaged red blood cells definitively confirmed splenosis. The patient improved clinically and was discharged on oral levofloxacin with outpatient hematology-oncology follow-up. Figure 2. Technetium-99m heat-damaged red blood cell scan showing abdominal splenosis. Discussion. Splenosis results from mechanical seeding of viable splenic tissue following splenic injury, with implantation facilitated by rich peritoneal vascularization. Although often benign and incidental, splenosis poses a significant diagnostic pitfall when discovered during evaluation for unrelated pathology. In this case, acute sepsis prompted imaging that revealed disseminated intra-abdominal nodules, initially concerning for metastatic disease. The patient's remote history of traumatic splenectomy proved critical in reframing the differential diagnosis and preventing unnecessary biopsy or surgical exploration. Splenosis nodules typically demonstrate imaging characteristics similar to native splenic tissue, but lack pathognomonic features on conventional CT or MRI. Functional imaging with technetium-99m label heat-damaged red blood cells remains the diagnostic gold standard due to its high specificity for splenic tissue. Mild elevations in tumor markers as observed here can occur in systemic infection and should be interpreted cautiously to avoid anchoring bias. Conclusion. This case is notable for the incidental identification of splenosis during an episode of bacteremic sepsis, underscoring how acute illness can mask clinically silent anatomic variants. Awareness of splenosis is essential when interpreting imaging in post-splenectomy patients, particularly in high-stakes settings where malignancy is considered. Thoughtful integration of history, imaging, and laboratory data remains paramount in avoiding diagnostic momentum and iatrogenic harm.